Welcome to this presentation prepared for the Second International Conference on Aging in Society, being held in Vancouver, BC from November 5th to the 6th, 2012. I'm Dr. Deborah Sheets, and I'll be talking today about the findings from a study that contrasts widows with married older women on indicators of health and social participation. My colleagues and I are from the University of Victoria in BC, Canada. Our research is part of a Canadian Institutes of Health Research funded study on women and health promotion. Health promotion is a set of strategic activities designed to positively influence health and quality of life. While women's health in general compares favorably to men's in Canada with respect to mortality, over their lifetime, on average, women experience higher rates of chronic disease and a greater burden of disability than men. Evidence is growing that shows that health care interventions, including those that could be understood as health promotion, may be more effective if they're designed with gender in mind. Our research uses a life course perspective, which refers to a multidisciplinary paradigm for the study of people's lives, structural contexts, and social change. In particular, the life course perspective directs attention to the importance of time, context, process, and meaning on human development and family life. Events and roles do not necessarily proceed in a given sequence, but rather aging and developmental change are continuous processes that are experienced throughout life. The social determinants of health are the conditions in which people are born, grow, live, work, and age, including the health system. These circumstances are shaped by the distribution of money, power, and resources at all social levels. The social determinants of health are risk factors that contribute to health inequities, which are the unfair and avoidable differences in health status that occur within a population. Adopting a life course perspective directs attention to how social determinants of health operate at every level of development, from early childhood to adulthood, to both immediately influence health and provide the basis for health or illness in later life. It's important to understand how social determinants of health influence health and cause disease. Two explanations have dominated the discourse. The cultural behavioral explanation is that individuals' behavioral choices, for example, tobacco, alcohol use, diet, physical activity, are responsible for their developing and dying from a variety of diseases. The materialist structuralist explanation emphasizes the material conditions under which people live their lives. These conditions include availability of resources to access the amenities of life, working conditions, and availability of food and housing, among others. Yet much of the Canadian discourse on health and disease remains focused on lifestyle approaches to disease prevention rather than the socioeconomic circumstances which play the major part in subsequent health differences. It's apparent that the economic and social conditions, the social determinants of health, under which individuals live their lives, have a cumulative effect upon the probability of developing any number of diseases. This has been repeatedly demonstrated in longitudinal studies. Women are economically and socially disadvantaged across their life course compared to men. Being female is an experience that causes a pathway effect. It sets women onto trajectories that influence health, well-being, and competence over the life course. Women do significant work in the private sphere as mothers, caregivers, wives, and more, which is not financially rewarded. In later life, the disadvantages of this lower socioeconomic status are reflected in higher risks for poverty, chronic health conditions, and other health inequities. Our research question here was, do married, common law, or widowed older women, ages 60 to 74 years old, have different health status, that is, physical, mental, and behaviors, social economic status, and social participation? For our study, we used the 2008 to 2009 Canadian Community Health Survey data. Our sample focused on women ages 60 and older. The number of married women, 2,266, was nearly twice that of widowed women, 1,164. Our analyses compare married women versus widows. I will be presenting descriptive statistics that show three age groups, 60 to 64, 65 to 69, and 70 to 74. I will conclude with odds ratios from logistic regressions because they provide a sense of the health and social risks for older women who are married versus widowed. Our first descriptive chart, this pie chart, contrasts married versus widowed older women and shows that married women tend to be younger than widows, as we might expect. At age 60 to 64, 44% of women are married, but by age 70 to 74, only 24% of women are married. At age 60 to 64, 24% of women are widowed, but by age 70 to 74, 44% are widowed. No differences in ethnicity were found for married versus widowed older women. In terms of education, widowed women had lower levels of education. Nearly one-half of married women were post-secondary or college graduates, compared to 36% of the widows. 44% of the older women who were widows did not graduate from high school, compared to 28% of the married women. Widows report substantially lower incomes than married women. 38% of widows report an income of less than $20,000, compared to 5% of married women. 22% of married women report an income that's greater than $80,000, compared to only 5% of widows. While some differences might be expected between a one-person versus a two-person household, income levels of less than $20,000 raise concerns about poverty. The research literature supports this economic risk, which is associated with becoming a widowed older woman. Additional longitudinal data are needed to investigate the changes in income that occur with widowhood for older Canadian women. In terms of health status, widows report poorer health compared to married older women. 21% of widows report fair or poor health, compared to 14% of married women. When we turn our attention to mental health, it was similar between married women and widows. More than 70% report that their mental health is excellent or very good. In terms of lifestyle risks, about half of all married women report regular alcohol use, compared to 38% of widows. However, widows were more likely to smoke, 16% smoked, than married women, which was 10%. And widows had a nutritional risk, 47%, that was much higher than that of married women at 30%. Now I will present some findings from the logistic regressions, and these are all odds ratios. Overall, widows were 6 times more likely to have a lower household income compared to married women. In terms of health status, there were minimal differences in the physical health between married women and older women who were widows. However, widows were 1.6 times more likely to report depression risk than married women. Health habits. Widows had 1.8 times lower alcohol risk than married women. Widows were 1.6 times more likely, though, to have a tobacco risk than married women. And widows were almost 2 times more at risk for nutrition compared with married women. In terms of social participation, we found that widows were 3 times more likely to lack companionship. Widows were 2.4 times more likely to feel left out. Widows were 2 times more likely to feel isolated. Interestingly, widows were 1.2 times more likely to participate in clubs and fraternal organizations. In conclusion, widowed older women appear to face greater economic and certain health and social risks than their married peers. Widowed women are not at risk, though, on all indicators. For example, widowed women did drink less regularly than married women. However, widows do have high risks on several lifestyle factors, such as nutrition, tobacco, and also social indicators, social isolation, that could be effectively addressed with health promotion programs targeted to this subgroup of older women. In particular, it was interesting to find out that older women who are widows are more likely to participate in clubs. This suggests that targeting innovative women-centered health promotion programs to older widows might be beneficial in addressing some of these health and social inequities. The educational differences between older women who are widows versus married was also striking. Health literacy may be an issue for a subgroup of older widowed women that needs to be considered in planning health promotion programs. Clearly, mixed method longitudinal data is needed to allow researchers to explore in more detail the textured patterns that influence transitions in older women's lives, and the impacts on their health. Research that focuses on older widowed women is needed to generate more knowledge to guide health promotion programs. In conclusion, thank you very much for the opportunity to share our findings. I hope that you have a good conference. Please contact Dr. Lynn Young via the email on this slide if you have any additional questions.